Hello, and welcome back to the Galactosemia podcast. This week's episode is with Gillian Sapia. She leads advocacy efforts for the Galactosemia Foundation. She works a ton with the FDA and with Congress on behalf of those with galactosemia. Initially, I had planned for this episode to be a lot about exactly that, advocacy and how to get involved. But as Gillian and I talked through some things, I really wanted her to be able to first tell her story and what her journey has been like so far. So that's what this episode is, and we are going to sit down again soon to really dive deep into what the current state of affairs is like with the FDA, what she's working on, and how people can be involved. But that's going to be a separate episode. As always, episodes of this podcast are released early and ad-free on our membership site, thegalactosemiapodcast.com. A big thank you to Katie Stickle and the Stickle family who made a generous donation to our project. We do fund everything for this podcast out of pocket, so if you'd like to join or you want to donate to help the cause, you can do that at thegalactosemiapodcast.com. I have some really exciting things planned in the next couple of months. I don't want to speak too early, but I'm working on some ideas that I think are going to broaden our impact in the community outside of just podcast episodes soon. So more on that to come, but definitely stay tuned and subscribe if you haven't already so you don't miss a thing. Okay, that's it for now. Please enjoy my conversation with Gillian Sapia. Today, I am joined by Gillian Sapia, a registered nurse, rare disease advocate, and a mom to Penelope, who lives with classic galactosemia. Gillian leads advocacy efforts for the Galactosemia Foundation. She works with Haystack Project and the EveryLife Foundation, and she helps to educate and mobilize families in the rare disease space. She brings just a wealth of personal and professional experience, everything from ICU to Capitol Hill, and I'm really honored to have her here. And we have a ton to talk about, so welcome to the show, Gillian.
Thank you so much for having me. I'm really excited.
The pleasure is ours. So the first question I always like to ask, and I forgot to do this last week with Britt, so I wanted to make sure and do it with you. I always like to know at the very beginning how you describe galactosemia to someone who's never heard of it before, because especially whenever I first got the diagnosis for my son, it was one of the questions that I struggled with the most was how do I talk about this to a stranger, to his daycare person, to his grandparents, to people who just kind of are curious about this rare disease. Over the past years that you've dealt with galactosemia, how do you tend to describe it?
So I definitely had a lot of those issues too, describing it. It's very difficult to describe because it's not an allergy. It's not an anaphylactic response. It is a metabolic disorder. And so what I will tell people, because you get the response, oh, I know what you're talking about. Like, oh, I get it. I understand. We know how to deal with allergies. And it elicits a lot of anger. I've gotten used to it now. So I just say, she has a rare disease, and it's kind of like diabetes, but with milk sugars, and she has no cure, and she has no treatment. So the only option is that she remain dairy-free, and that it could be in bread, it could be in items that you wouldn't think that would have dairy in it, and here's her bag of food, and that's what she's allowed. And that's kind of what I stick to. Because I think because diabetes is a more common prevalent condition, a lot of people understand or know. And it really is, for us, a lot about diet, even though we also know that the body makes its own amount of galactose. So I try to just keep it simple.
Yeah.
Simple, straightforward. Because no matter what, when you're describing it, I don't know why, you just get emotional. Like, why don't you understand me? Okay? Like, she is special. Like, I know all children are special, but she really is special, you know?
No, I do. It's that walking that line between, like, especially like what you said really resonated with me of like people will go like, oh, I understand. And it's like, I want to be like, no, you don't. You think you understand. You don't understand. You don't understand on the level that I understand. Right. And you get very protective, I think, of the diagnosis and of not wanting to get it confused with something like lactose intolerance, which is what the milk thing usually is. Oh, lactose intolerance or dairy allergy. And it's like, it's none of those things. It's actually something that's ultra rare.
Right. And you know what? Like back to my advocacy, that is the first advocacy that you do. Just that. teaching somebody that it's rare, teaching somebody to listen to you. And I like that one little part when you talk about, like I talk about advocacy, it doesn't have to be legislative advocacy, but the advocacy you do every day at Dunkin' Donuts, at the restaurant, when you're explaining it to somebody, you kind of should treat it like they don't know, so let me politely educate. And it's hard because I know I definitely had moments where I was like, you gave her a donut? Oh my God. And I remember it was like ballet class and they gave donuts and they started gaslighting me and making me feel like a horrible mom. And I was just like, everyone was looking at me. I was so embarrassed. And, you know, I have so many failures learning to be a rare disease mom. And I learned from that experience, like, I need to come at this at a different angle. And I need to educate people. And unfortunately, some people aren't going to get it. And that's when I walk away, you know?
Can you tell us a little bit about that time, what that, they were at ballet class and they had donuts for everybody and they gave one to Penelope?
Yes. And it was the first experience of her getting milk. And I already...
How old was she?
Oh gosh, maybe 2 or 3. And by that time, I wasn't into advocacy just yet, and I was still learning so much, and I had so many emotions, and I had so much frustration and anger. Like I had a lot of built up anger. And I think that was actually a big turning point for me, the donut situation. And there was another situation at school where I said, there are people who are not going to be willing to listen to me. And that's when I walk away. And we actually took her out of that program because there was a lot of things like, unfortunately, in dance, there's not a disability. They don't have to accommodate you in any way. And I asked a couple times and they never accommodated because she has, she's been diagnosed with autism and sensory processing disorder. And, you know, you're trying to advocate. And that's when this isn't acceptable. Let's move on. And I don't write a bad review. I just move on and find the people, like the good helpers in the community. And we joined soccer, and there were good helpers in the soccer where I explained what was going on. And the little girls took such good care of her. And the soccer dads like took such good care of her. And I'm like, that's where we go. You know, go to the positive, leave the negative. And right now she's in ice skating, and I feel very happy where she's at. I'm so nervous. But when I went there, the director said, attention, everybody. This is Penelope. Penelope has a dairy allergy. Penelope also has to wear a helmet. Penelope had brain surgery, so she needs to do these things. And I'm like, when she's older, Penelope will probably be embarrassed. But right now she's like in the spotlight. But as a mom, I deeply appreciate that. And so I'm going to support that company. I'm going to support them because they're supporting my little kiddo.
Right. And I feel like that's such good. A lot of the things that I find through this podcast is just experience wisdom. So wisdom that people have gained through experience. And that's like this, like, we'll go towards the good and leave the bad. Yeah. Because this is the type of experience that isn't good. And then this is the type of experience and what it should feel like and what it can feel like. And we need to find those. That type of stuff is so useful and valued. I know just for me specifically, we've got so much to get to. You and I, we sat down the other day and I feel like we could have talked for hours just about all of the different stuff that you do and that you're involved in. But I want to rewind a little bit and kind of start from the beginning and talk a little bit about who you kind of were before Penelope and then what Penelope's birth was like, so that anybody who doesn't know you already can kind of understand your story and where it all started for you. So can you walk us through your journey kind of at the beginning?
Okay. So I guess, my journey, I was a nurse and I loved nursing, and I always wanted to work with the sickest of the sick. And I worked in the ICU of a long-term acute care. So these patients this is your last stitch effort, last hope. So it was a blend of, so everybody was like intubated, they had a tube feed,
Wow.
Completely, just like wounds, like you name it, I saw it. These were the sickest of the sick that I worked with. And my journey was definitely interesting. It's so funny when you look back and you reflect on your past and how much of that information shapes what you're currently doing now. And I remember getting to a point where I was getting really frustrated. I'm a patient advocate to the core. And policies and procedures were also my thing, which is so weird. I don't know why. I'm very black and white. And when you have a policy and procedure, I'm like, well, why do we have this? What's the point of this? And it kind of drove me to question certain things about patients, like, are they getting the best care? Are they getting the best quality care? Like, quality care of people at the end of their life was really important to me. I met patients that had ALS, and ALS is actually considered a rare disease. And because it was a long-term acute care facility, people who were ventilated who had ALS, also even muscular dystrophy. There's Duchenne's. There's a lot of rare disorders that I was dealing with.
Okay.
But I was always a patient advocate. But I remember like coming home to my husband and like, I'm going to lose my job. I am going to lose my job because I'm arguing with people. And eventually I left. I know it's so bad.
No, I think back about like I've only known you for a short while, but on the call that we had, and you're just very animated and very passionate about what you do, and I can just see like, yeah, if you believe something, you're gonna have arguments with, like, I could see you coming home being like, I'm gonna lose my job because I'm just like, I'm getting into it with these people. Like, that feels like it's very on point for you.
Yeah, it's very true, and it's so funny because I am very awkward and shy, and I don't know, nursing empowered me to get to that strength. And I remember one of my last times at that hospital, I was talking to a physician and I convinced him to change his mind about something. And I told him, I said, I'm gonna go to bed tonight and I'm gonna put my head on my pillow and I'm gonna feel real good about advocating for this patient. Are you? And he changed his mind right then and there. And that's when I knew it was time for me to leave, because I was going to get fired. I was getting really angry. I actually went into drug and alcohol treatment, and a big history I don't share with a lot of people, but I'm in recovery 20 years.
Wow.
So I really...
Congratulations on 20 years.
Thank you. I really like mental health, and so I thought I would go there. And my job there was to manage the medical department, get it up to date, get it safe, get it compliant. And I don't know if you know about Joint Commission accreditation. So Joint Commission accreditation is like the big accreditation that every major hospital has. They make the rules, the policies and procedures. Like I said, like my background, I love the policies and procedures. So my job there was to help them gain Joint Commission accreditation. So I had to write the policies and procedures for the entire medical department. And it was like a 100-bed treatment facility. But even then, patients mattered. Their quality of life mattered. It was really important to me. And I felt very empowered there because patients and people who were working there, like therapists who are not necessarily medical, were saying, thank you for coming. Thank you for being here. This is amazing. You're putting patients first. And I really enjoyed being there because I really felt validated that the patient was important. And that was so vital to me, that patients come first, their voice comes first. And I still have people, even from the long-term acute care facility, that reach out to me and say, my mom has passed, but I remember you. I remember the care that you had. Or people who are at the drug and alcohol facility, they're doing really well, and they'll reach out and they'll give me like a short little, you did this for me. And it's so rewarding to see people having a good experience in a system that is not really set up for patients being completely first.
Yeah, and you see that patient first care kind of in your day-to-day advocacy and like how involved you are with all of the rare disease community, and we'll get into that a little bit. When did you get pregnant? What year did you get pregnant with Penelope? And at that point, did you know anything about galactosemia? I assume you didn't. And then like, how did that progress?
Okay. So this is also an interesting story. I was told I couldn't get pregnant, and I had to have IVF, and I had premature ovarian failure, just like a child with galactosemia can have. And it's interesting. We don't have a lot of carrier status research, but it's interesting that she'll have possibly the same thing that I did.
Yeah.
So I had like no eggs. And during the process with IVF, you do genetic counseling. So my husband got screened, I got screened, and they picked up that we were both carriers of cystic fibrosis. And that has a 25% chance of you having a child have the disease. And so they were like, IVF is a really good option for you. And so when they picked up on that, we were focused on that. And this was years in the making, and it's a lot. And you're on a lot of hormones and a lot of treatments and a lot of surgeries. I went through a lot. And I only had one egg. Wow. I only had one egg that made it. And then came genetic testing for the embryo. And we paid $20,000 out of pocket to have this embryo tested. And it came back that she actually, they can tell you if it's a girl or a boy. So we found out it was a girl, and we already had a name. And none of the cystic fibrosis did not show up. Nothing came up, healthy embryo, all good to go. And obviously I got pregnant. Pregnancy, I ended up at 20 weeks on bed rest. I got super swollen, and they were worried about preeclampsia. But again, I always think about, I wonder if it was like, there's something going on there that causes other issues with me. You know, you're constantly thinking like, what's going on here? So eventually my due date comes, and I have a C-section, and there's so much pain and anticipation when you go through IVF, and then you have your miracle, and your miracle is put on your chest, and you're just like, this is the most amazing moment in my entire life. And I remember my husband was in the room with me, and I looked at him and I was like, I don't ever have to cry ever again. I got my baby. And oh my God, it's just like, oh, I should have never said that, you know?
And at that moment, the gene was altered, the galactosemia.
Oh my gosh.
Sure.
So I had this life-altering thing happen. It was beautiful. And I take my baby home, and oh my God, I got really depressed. And I knew, because I'm in recovery 20 years, I knew that I was going to be at risk for postpartum depression. So I was struggling with that already. And I don't even remember. It's like such a blur, that all that stuff that happens. So he took her home, and she was like an easy baby. She didn't cry, and I was a new mom, and she was doing well from what I thought. And then we got the call about the newborn screening. And I even saved the voicemail. I still have the voicemail of them telling me that there's a positive, because the way they said it was like non-emergent. A matter of fact, like nothing big deal, no big deal. And it's so funny because my baby was born in August, and we are in Florida where it's really, really hot. So when we talk about those positives being treated like false positives, that's exactly what was going on.
Yeah, and what you're referencing to is something that I've said on the podcast, and I told you, which was like when we got our diagnosis, it was very much said alongside of, it's probably a false positive. It's summertime. We have a lot of false positives during the summer. It makes there be more false positives. And so it gets that thing into your head that's like, this is probably, don't really worry about this. Like, you probably don't have to worry about this.
Right. And on top of it, I'm like, we had all that genetic testing.
Right.
It's foolproof. We had all of it. I did all of the genetic testing, so we're good. But they were very nonchalant about it, and it was like a holiday weekend or something, and we got it late, and then they told us to come in, and we come in, and the doctor, she had lost a little weight, which is typical, after a baby is born. And that's the hardest thing with galactosemia, is that a lot of the newborn signs are the same as like metabolic crisis, the jaundice, a quiet baby. You wouldn't think anything of it, you know?
The lethargy. They just went through this trauma of coming out of a womb. Of course they're lethargic.
Oh God, I have the best baby.
Yeah, it's just chill. I just have a chill baby. What are you talking about?
Totally bragging about it. It must have been all that Bob Marley,
Right. We played classical music. It's not a rare disease. Meanwhile, you're poisoning your baby.
I know. And then you go in, and I'm a nurse. But also too, I am not a baby nurse. A pediatric nurse is totally different. It is a totally different field. And so when I went to the doctor, we're there and they're explaining this to me, and I'm overwhelmed. And I'm like, they're trying to explain it to me, but they're making it seem like it's a like a dairy allergy, like a lactose intolerance type thing. Like, this is fine. So they did a head-to-toe assessment. She was hypothermic. They ignored it. They said, I think it's just because she's in a diaper. Maybe it's just like the environment that she's in, and once we bundle her up, she'll be fine. She was jaundice. And then the nurse went to go weigh her, and so we took the diaper off. And she had explosive diarrhea. And I'm thinking it's the meconium, which is like the first, like after it's a gross poop after a baby's born.
Black tar,
Yeah. And that's kind of what it looked like. But the nurse, her facial expression, like looking back on it, I'm like, I should have paid attention to that, because she's like, I've never seen anything like it. And as a nurse, you are composed. There's no grossness. There's nothing messy. But I should have just paid attention to that. And I didn't. And the doctor said, everything's fine. Just switch over to soy. And we'll have testing done, and we'll follow up with you in a couple of days and weigh her and see if she's putting some more weight on.
So they did tell you to switch over to soy, though.
Yeah, no, that's the one thing that they did tell us to do, because I've definitely heard a lot of different stories on that, which is interesting. So we went home, and man, I just had a C-section. I'm exhausted. I think it was about 5 o'clock. We're getting ready to, relax. I'm about to take a nap, and all of a sudden I hear my husband scream. And I go downstairs, and my baby's gone. And it was traumatic. It was awful. My husband was trying to take her temperature and couldn't even get a read on it. For the longest time after, like, he didn't want to do anything. He didn't want to see a thermometer. It was just so. And he's like, "Would we call an ambulance?" And I said, "No, we're not calling an ambulance. You're getting in the car and we're driving right to the ER."
So when you say gone, you mean like
unresponsive.
Unresponsive.
So there's a pinch test on your foot where you can pinch nothing, completely gone. I'm trying to stimulate her, trying to rub her chest, and I'm just screaming, "Penelope, Penelope, Penelope." And it's so crazy when we talk about people being in the ER and you're waiting and you're waiting and waiting to be seen. And then I'm showing up with my baby and I'm saying, "She's gone. Wait, there's no response." And I'm trying to pinch her. And as soon as I show them I'm pinching her, they take me right back. You don't want to be that person that's being taken right back. So we got there, and her glucose was in the 30s. And that's like comatose. When like you talk about a diabetic who can go into a low blood sugar, that affects your brain, And they had a lot of trouble getting her blood sugar up. And the doctor said, "Can I talk to you?" And I said, "Yes." And he's like, we don't know what to do for her. We're going to have to send you to another hospital. And that was like a shock. Like, what do you mean? And so I kind of like go into like nurse mode, and I don't think it's completely hit me like what's going on, because really nobody knows what's going on. And we had to go into an ambulance, and I had to sit in the front, and they had the camera in the back, and I could watch what was going on. And, you know, the gentleman's telling me everything that's going on. And it's so crazy because this tiny little thing goes into this huge gurney, and they're just completely swallowed by all of the machines and everything that's going on in the back of the ambulance. And I remember she crashed, her sugar crashed a couple times in there. And he's like, very calmly, which I appreciate it, he's like, her blood sugar is low. You're going to see a lot of movement back here. We need to get her back. And so the drive there was just torturous. And we finally got to Joe DiMaggio, and getting her blood sugar up was just torture, and getting answers was really difficult. The doctor came in and told us what was going on, and that she is in metabolic crisis and her liver is shutting down. And we're going to do everything. We're going to go put you in PICU. And we went to PICU, and I hate telling the story. I've told my story so many times, but it is so traumatic, and it is just so hard. Because I remember going to Dr. Binky. Dr. Binky is now retired, but he was the doctor who saved my baby's life. If he wasn't there, I don't know if she would have made it. But I remember asking him, I'm like, is she going to make it? Is she going to make it? And he was like, we've done everything that we can, and that she's going to have to fight. And I remember after hearing that, it like finally hit me. Like, this could be my last hug. This could be my last picture. And I think I stayed up for like 3 days straight, like just completely like, this could be the last right. Everything. And it's so crazy how it's just, the experience at the time was so crushing. And the whys. Why is this happening? What did I do wrong? And then the breastfeeding and the whole experience. There's so many details of my story that are important. I remember it was like the least thing that I was worried about, but I was completely engorged and leaking breast milk all over the place for over a day. And I kept asking, can I get a breast pump? Can I get a breast pump? And I felt so, I don't know even what the emotions are of it when you're asking for help. It's like, I guess the advocacy starts kicking in when nobody's listening. So I finally went up to the desk. I opened my sweatshirt and I said, somebody please get me a breast pump, because I had been there for so many hours. I was completely covered in breast milk. And you know, there's so much that goes with that, the breastfeeding. Like, there's so much emotions. Like, there's this stigma that if you don't breastfeed, you're a bad mom. And I remember we're in the PICU for galactosemia, for her metabolic crisis, and we sent the lactation consultant in and said, how's breastfeeding going? And I was like, that anger, I was like, we're here because I breastfed her. And it was awkward. And she like kind of slowly backed out. And she was like, well, you know, you can get free meals. I'm like, it was just, you know, and that's why it's like, when you go through those experiences, they empower me to stand up for patients that are going through it now.
Yeah. So
she had a lot going on. She had stacks of IV drips. They had to put a femoral line in. They had to put a NG tube in to feed her. And she survived. She made it. And I remember she started becoming a very cranky baby. And she was crying a lot. And I remember Dr. Binky coming in and said, a crying baby is the most alive thing about having a baby. she's crying, she's alive. And even to this day, when my daughter's like on the floor having a tantrum, I'm like, oh, she's alive. And I love her.
Thank God you're having that tantrum and you're crying right now. I'm so happy.
And it's so true, though. Like,
Yeah.
you have these parenting moments. I'm definitely much better on this side than I was in the first couple of years.
Sure.
With managing those moments where you're just like, I'm going to rip my hair out because parenting's so hard and it's so frustrating. But I definitely did. I struggled with depression, horrible, debilitating depression. And they put me on everything that you possibly, they tested me for everything. And hindsight, I think it's because I went through IVF, had a baby, and lost all the hormones. Then I had a traumatic event, and I already had depression. So it was like the perfect storm for, what did they call it? They called it treatment-resistant depression. And so I'm struggling with this and having a baby who needs me. And I remember I had a really good friend. I am so grateful for her. She was like, Gillian, this isn't you. And she's like, it's okay that this is where you're at right now. She's like, but I see you one day being like the champion of galactosemia. And that's when I kind of like woke up and I said, enough. And I got a new doctor, like my mental health, my psychiatrist got a new doctor, started over and started my journey. And there's a lot more to my story. And I guess we don't have time to go into it, but
we have time for whatever you want.
Penelope.
The thing is, first of all, thank you for being so vulnerable. I am just amazed at like specifically the mothers in this community.
I know.
My wife included, and then all of the ones I've talked to and all of the ones I haven't who share and go through this. The mothers continue to be like the strongest people I've ever seen in my entire life. It is the things that you all have had to go through and like the amount of, like you said, like details and complications and layers to everything and stories that everyone else doesn't get to see or have to see, but you have to go through. And I really do believe that there's like a huge power in hearing that other people are going through it too.
Yeah.
And so that's why I just have such appreciation for like you being so vulnerable and sharing your story. And it's why if there's more like to share, like that stuff's important. And, you know, I know Britt said this last week, like, I feel like people have already heard my story so many times. And the thing that I think about is like the people who have not gotten that galactosemia diagnosis haven't heard this story yet. And they're going to find this podcast and they're going to hear that story and it's going to make an impact. And so I want to hear the other things that how, you know, Penelope, she's like 7 years old right now. Yeah. So you've got 7 years of like stories to give us.
I know. It's crazy. And it was so funny because I become so fact driven with my legislative advocacy. The other day when we were starting to get into the sentiment, I was like, wow, this is a lot and it is important. These stories are important because like even the story you shared, my dedication now to like newborn screening, the weather, someone else commented about snowstorms, and it causes delays. And I was like, there be so many layers and a story is so important because you just don't know. And even the good stories, people who have success stories, what did they do? Or their newborn screening was successful and really early. Well, what state do you live in and what's their policies? So, yeah, it's just crazy when you tell your story, like you don't want to be over dramatic or like poor me, because no poor me's.
Right.
So Penelope has 2 other rare conditions.
Okay.
And it is important, like you said, because galactosemia can have what are called comorbidities. So you can have galactosemia and asthma. You can have galactosemia and Chiari malformation and another genetic disorder like Penelope. So Penelope, we started getting into, Babel boot camp. I think Penelope was 3 months old and we enrolled in Babel boot camp. even though I was depressed, we were moving forward and we started getting into the research, and they were amazing. I felt empowered when there was no solutions, no resources. They put me in the right direction. And that's why I think, a lot of the participation in research or surveys can point you in really good directions of experts. And I know Nancy Potter, if I needed to email her today, she would, what do you need?
Absolutely. I texted her a week ago and I was like,
right,
hey, I need help with this thing. And she responded and sent me an email that was entirely too long for the time that she has to give to me.
I know. And it's just amazing. So I started getting into research for Penelope because it's the only option when you have no cure and you have no treatment are these research projects. And so my God, the timeline's so faded now. But around 2, I started noticing absent seizures. And there's not enough research about the seizures in our community, whether it's a comorbidity, like you have galactosemia and a seizure. So an absent seizure, people need to recognize what it looks like. I think that if people knew earlier on what it looked like, I'm thinking people might look to their doctor to get diagnosed with seizures, because I think there's probably a lot. This is my hypothesis, that there's a lot more.
And tell us what absent seizures look like.
So an absent seizure looks like spacing out, ADD. Like, I'm going to look over here for like 5 seconds and I'm not going to pay attention to you, just staring off into space. But as a nurse, I can spot it. And I remember I was just doubting myself. I doubted myself with every little detail that I was like, something's off. There was some point where I was like, my mom gut is always right, and I'm never going to doubt myself ever again. And we went to the doctor, and they started evaluating for her seizures, but she was having them like one after another, after another, and after another. And so she's staring off into space. And for me to assess whether she's staring off into space or having a seizure, I pinch her. It sounds awful, but when I just like squeeze her nose. And she has such sensitive sensory processing that if I did that when she's not having a seizure, she responds right away. Like, don't touch me. Like, I'm overloaded. Don't touch me. But when she's having a seizure and I simply just like go like that to her nose, like just pinch her nose, she does not respond whatsoever. And that's how I saw the difference. And there's also, they're like, I forget what the movement is called, but they literally can stare out into space and smile or even like move their hands. And it's an automatic response. I forget the name for it, but it kind of looks like they're responding to something, but it really is part of the seizure. So she could be staring off into space for 5 to 10 seconds and just smiling. And if you're not in the medical field, if you're not a nurse, you wouldn't know to look for something like that. So I took them in, and my first doctor didn't believe me. So we went to another hospital. We went to University of Miami, and we had the neurologist look her over. And she was like, this is probably seizures. She's like, but it's not galactosemia. I've never heard of seizures for galactosemia. It's just not it. And so I was like, okay, all right. So we have this other thing on top of it. I think at the same time, I also got an expert opinion from Dr. Berry to get his explanation of, and like most people say, there's just not enough research. We don't know. And the research that I have done, that I've looked at myself, there is some demyelinization of the brain. There are hypointensities in the white matter. So the brain is affected. Is it affected enough to cause a seizure? We don't know. And that's kind of how Dr. Berry gave a very, we're not sure. I think there's about a 25% part of the population that has seizures. But seizures are a common prevalent condition in the regular population. So like I said, if you had asthma and galactosemia, they're two separate conditions. So genetic testing for seizures is really important. So we got further genetic testing for seizures, And that's when we found out she had this like other gene, which has no cure, no treatment. It's of unknown significance, but they think that it causes behavioral issues, some learning and IQ issues. But it came up, but it had nothing to do with seizures. So we started going through the process. We went into the hospital. We had an EEG. That is no fun with a 2-year-old being hooked up to a string and can't move for 2 or 3 days. And Penelope seizures were always unique. So we always ended up staying for like 4 or 5 days, where typically you stay for 1 or 2. Okay. And they diagnosed her with seizures. They started her on medication. And that's when they said she's at risk for what is called status epilepticus, which means she can have a seizure that doesn't stop and will kill her. And God, we got through birth and now we have to deal with this. And I have to deal with like putting my baby to sleep. And like, what if she doesn't wake up in the morning, you know? And I remember like, it's just a whole nother thing to wrap your brain around. And my husband and I think about it all the time. Like, even now, like if she sleeps in late, we're far from it. Her seizures are well controlled, but we just kind of like have that like in the back of our minds, something could happen, because so far a lot has happened. Right. It's true. And it's so like, a lot of people around us like to minimize what we go through. Oh, it's going to be okay. Oh, it'll be fine and everything. I'm like, for her, it might not be. So that's very real for us. And we've, worked around it. So
the medicine, the medicine they have her on for seizures, is that what helps? You said you're in they're well managed now. Is that the medicine that she's taking that manages the seizures?
So I have so many layers to my story. So her seizures, a year later, we applied to go into the drug trial for Govorestat with applied therapeutics. And so about a year later, she was having issues, and they kept telling me like, this isn't it. She was having other issues with another thing that was going on. And finally, like it was the day before we were supposed to fly to Atlanta to take our first dose and to have our first whatever. And Penelope stopped walking. She actually started walking like a drunk pirate. It was, what is this? Yeah. And so I called the doctor and I said, something's really wrong. And typically when you have seizures, they order an MRI, but our first physician never ordered the MRI. So this physician ordered an MRI and found that she had a Chiari malformation. And I think like less than 1% have to have surgery. So
what is that? What's a Chiari malformation?
A Chiari malformation is where there's not enough room for the brain. And so the tonsils or part of the brain actually seeps down into your spinal cord and cuts off the cerebral spinal fluid from your brain.
And they found that by the MRI?
By the MRI. So we were supposed to go to the drug trial. COVID came, canceled the drug trial. This happened. That very same week, we were in the hospital having brain surgery.
Okay.
And, my husband's tough. And was tough, like tough. The brain surgery put him over the edge. And I've never seen him cry so hard when they rolled her back to have brain surgery. It was just like, when is this going to end? It's never going to end. And it's so funny how when you have a partner, I'm a nurse. So like, I remember it was like, even after this, I was like, we need to do crisis management, because there's going to be another time where something's going to happen and we need to manage this together. Because we were arguing innocently. I mean, there's just a lot of decisions to be made and a lot of choices to be made. Like even to go into a drug trial. Do you want to go in the drug trial? I want to go in the drug trial. I don't want to go in the drug trial. So there's a lot of communications. And so what I found that when we're in crisis, I'm good. I'm really good. When we're on the other side of crisis, he's really good. And so it kind of balances it out. And so I think that was a turning point where I realized when we're in crisis, I need to step up. And after, when Penelope's fine, I have the letdown where this is emotional and I can't handle it. And that's when he steps up.
Yeah.
And so the Chiari malformation, they said, did not cause seizures, has nothing to do with seizures. And so you think the brain, and they're like, no, it does not cause seizures. It just, and there's complications with that where even now, 7 years later, she's falling a lot and I'm worried. So I have to get an MRI for her. She has what is called a syrinx, and it is a cyst on the cord. And sometimes it dissolves on its own, but we haven't been evaluated for it since all this happened. But as she grows, the syrinx can grow. And so it could affect her. So we're in the process of trying to figure that out as well. So when my baby's complicated. And so now when I go to the doctor, when I advocate, say it's a new person, I said, my kid's a 1%er. Yeah. If you think it can happen, it will happen. And doctors seem to recognize that. I don't know how, but I'm like, she's my rare kiddo. And you need to appreciate that for what you're doing right now. And so I found that most physicians, when I ask, the clinical guidelines, I need a bone scan. Okay, no problem. You got it. No questions. But that's taken a lot of time and advocating to learn what I'm supposed to say.
Yeah. So they found that the Chiari malformation, they said it doesn't have to do with seizures, but because of the seizures, she got an MRI that showed the malformation. So then they did brain surgery for that.
Yeah.
And then still is having seizures.
Yes, and she was still having seizures. So a year later, and that's that whole situation with the seizures was the tipping point for us going into the Govorestat trial. Because I was realizing that she's more, and there's lots of different views on progression versus not progression, the definition, the medical definition of progression or not. And I'm just I'm seeing my kid getting worse. And I said, let's do this. Let's see what this can do for her. And it's a placebo versus drug trial. So you had a 1 in 3 chance of having placebo. So we entered it in the drug trial, hoping that this could possibly help her seizures, help some of the damage from the sugar in her brain. She already was showing signs of tremors. She had occupational therapy through our state program. It's early steps here. Every state usually has an early intervention program. Advocate for it, get in it, find it. And it was so helpful to us because there were so many things that they helped me with. But when I had the occupational therapist, I'm like, I'm seeing tremors. Are you seeing tremors? And she said, I'm seeing tremors. So it helped me get some validation about what was going on, where I could go to the doctor and say, this is what's going on. So we're in the drug trial, and it's empowering to kind of feel like we're moving forward. Maybe we can find an option. And this is when you kind of, open Pandora's box. When you find out how unfair it is to be rare and to be in a drug trial and to know what happens at the FDA and how things work. And I don't think I'll ever be able to shut that box knowing what I know. And a lot of people don't know that the FDA in our system is not set up for us at all. And
by us, you mean rare.
Rare. I mean, there's 30 million rare Americans. There's 350 worldwide. And we are not included in insurance. We are not included in FDA pathways. And we're not included in CMS and insurance. And I did not want to get into politics. I did not want to get into advocacy. I just wanted to be a mom. And even now, I'm I just want to be a mom. I just want to be magic and fun. And here's some, oat milk and cookies. And we're in this drug trial, and we were supposed to get accelerated approval. And accelerated approval is a faster pathway for diseases that like rare disease, that don't have any treatment and have no other options. So they want to push that forward through the FDA so they can get approval. And we had biomarker data that was positive that decreased galactitol by 40 to 50%. And it was denied accelerated approval. And we were expecting for them to approve it. Because
what year was this?
This was, I think, 2021.
Okay.
It was January of 2021. We were supposed to get this approval. People were seeing great things. I honestly thought we were on drug because nothing was happening. Nothing was happening. We were fine. I think she's doing well. And I'm like, we need this. And I'm hearing all these great stories from everybody else. Like, this is great, blah, blah, blah. And this was our first grassroots movement. There was about a group of 20, maybe 10. It was actually probably smaller than that. 10 women, 10 moms calling the FDA, demanding answers. And that was the start of understanding how difficult it is for patient engagement at the FDA. And
what does that, break that down for me? What does that mean, how difficult it is for patient engagement at the FDA? Does that mean like how difficult it is for us to talk to the people who are making the decisions to approve the drugs?
Exactly. Okay. So this is important information to empower the community, and it's complicated, but there's no one person at the FDA that you can say, hey, this is going on. Can you please help me? There is no patient engagement at the FDA, and the FDA says repeatedly, there's engagement. We have engagement. We have websites, and we have forums, and we have forms, and we have all this stuff. And I'm telling you, for 5 years, I have emailed the FDA, and I haven't gotten a response that is significant enough for me that has established patient engagement. And it's just baffling, but I feel like that's a little bit of gaslighting and saying like, we have it. And then when you have something like Rare Disease Day at the FDA, they pick these success stories and put them up on a podium and says, these are our success stories. This is what they did. And then their patient foundation says, we did this, and this worked, and we did that. And I'm just like, I'm in the comment section. I'm always in the comment section. I'm like, well, how did you do that? We do that. We're not getting any response. What about us? I don't understand what's going on here. Yeah. And that's when I realized, like, God, there is no engagement. They're just cherry picking the success stories. And so 2021
fast track is denied.
And then the foundation, we're not formally an advocacy. They don't even have an advocacy section at the Galactosemia Foundation. It's the moms that are in the drug trial, busting their butt, trying to get involved in this. So in the background, and this is like very important, the Galactosemia Foundation for months work on getting what is called an PFDD. It's an externally led patient drug development. Patient-focused drug development meeting, sorry. So again, there's this, like, in quotations, patient-focused drug development. And you have to pay for that. The foundation had to pay for that. And that's like $150,000 to get your voice heard at the FDA.
So to set a meeting with the FDA that is focused on the drug development, like Govorestat, or something for the patients.
And so it's actually not for Govorestat. And these are the weird legislation and rules, and they sit behind these because it is law. When you talk to the FDA, they are not allowed to talk about proprietary information. So when I call and talk to them and I say, I want to talk about this drug trial, they say, I'm sorry, we can't. And they'll say it's proprietary information, and they quote the law, they put the number of the law, and I've looked at the law and I'm like, this is just some BS to me. But in addition to that, I found out this year that if they do disclose any proprietary information, I think they're one of the only government employees that has like a mandatory 5-year jail sentence. So that's just a conundrum, and that's not fair to them either, because I bet they really want to, and that's why I say it's not always the FDA, it's the laws that we're working with.
Right. And
it's just this cycle of craziness that you hear me about the common sense. Like, there's more common sense solutions than what's going on. And that's why the patient is just like behind a black curtain. Pharmaceutical companies, they are trying to make money, keep afloat, whether they're small or large. They have stock. Like, they can't talk to you, the patient, about what's going on because it could affect them financially, but we need the drugs, so they need to be financially okay. And then you try and talk to the FDA, and the FDA is like, we'll get in trouble if we talk about proprietary information and it's so complicated.
Right.
So the patient-focused drug development meeting is about establishing a burden of disease for the FDA. And it's not about talking about drug. It's about talking about, we would like treatment, and establishing that we do have burdens, and that the FDA literally has never heard of galactosemia before.
Yeah, and this is, Brittany talked a little bit about this last week because she talked about the Voice of the Patient report.
So important, such important work.
The way she put it was, this meeting led to the Voice of the Patient report, which anytime the FDA considers a drug, they'll pull this Voice of the Patient report for galactosemia, and that will be their reference for like what the decisions are and what needs to happen, and that kind of informs them. And so that's why this one meeting was like so important, right?
It is. It is. I, even now when I'm going to newborn screening, I go back to it a lot because I'm also have taken over as the principal investigator of a registry, and that documentation is such a profound collaboration of patient stories. And
what is the registry, and what is your role as the principal investigator?
So everything goes back to my experience with the FDA. You have to establish burden of disease. If you don't establish burden of disease as a rare disease, they won't approve a drug. They won't fast track a drug. They will see it as, so pretty much FDA is Googling, this is as simply as I can put it. FDA is Googling what galactosemia is, and like everybody else, minimizing that there's not really a problem. And I am looking at the patient registry where I want to find out all the problems so we can develop a burden of disease, but also pick out certain problems that hopefully in the future we can find treatment for. So, I mean, hypothetically, hearing issues, hypothetically, dental issues. Are we finding, like, you know how in the Facebook group, everybody talks about like what you see, and they find like things that like they have a lot of commonalities. So this kind of makes it official. And then I can put it in a document. I can aggregate the results and do a lot with it. I can share it with our researchers, and our researchers, off those surveys, those patient surveys that you've taken time to fill out, create treatments and options and interventions. And a registry is so important. And I remember we were trying to figure out how we were going to transition this. And because it was already in legislation, I realized at the FDA, establishing that registry was so vital. And I took that on in October. I'm still learning a lot, but that's when I realized with the newborn screening, wow, this registry could help us get the funding to get the point of care newborn screening. Because if everybody, so there's one part of the surveys that I was looking at, I was like, The average day of diagnosis is 5.5 days of the people who have filled out this survey. That's not like official, but I'm just saying that's insightful when you read everywhere, early intervention, newborn screening is early intervention. It's not if it's 5.5 days. You are giving milk, breast milk, that's killing them. And if you look at how metabolic crisis develops, obviously every kid is different because everybody makes a different amount of galactose and you have different pathways. And so everybody has a unique story where somebody at day 2 could go into metabolic crisis, or somebody at day 5 can switch over and be okay. But I'm like so all over the place.
No, it's fine. I want to steer us back to, so the registry, first of all, like, so you're talking about Galactosemia Foundation has a registry that's basically a log of everybody that has galactosemia. Is that essentially a registry?
So a registry is there's different registries. So there's about 8 surveys in there that can be quality of life. And they ask you various questions, demographics, where you live, do you have tremors, like they're patient surveys.
Do we, for our community, would we then want people to go fill this out at a certain point in their kid's life? Or like, how is this registry activated in the community? Because I'm sure there's people who are listening to this that are like, oh, I haven't filled out this stuff. Like, what do we tell them?
Yeah. And so right now, everything's on pause. I've taken over, and now I'm going through it with a fine-tooth comb to make it as, I guess, like, usable as possible. That's not a word, but
effective,
when you're doing this survey, I want at the end of the day to have a purposeful result. And so because I'm a nurse, I've also added another registry, a supplemental registry, because, and I don't even know how to approach this topic because it could be sensitive. I can do a head-to-toe assessment on anyone and say, like, this is probably what you're going to die of. You know,
Sure.
I observe so many things, and I have been to many conferences, and I've observed a lot of things that aren't being documented in a patient-reported survey, where if I was a doctor or a nurse, I can do assessment and see something that maybe you're not seeing. Or when you have a chronic illness and you are 60 years old, what is abnormal to you has become your normal. This is normal life.
Right.
And you might have significant tremors and some other neurological issues, but when it's chronic and it's all the time, that's your normal. And then at the same time, doctors will tell you everything's fine. Everything's fine because there is no cure and there's no treatment. So why are we going to do any kind of intervention or make you upset about this?
Right.
So it's a lot, but
yeah. So these are the registries that you said right now are on pause. Eventually we'll get to a place where maybe we'll have you back on and it's like activation mode, like everybody go to the
I'm
survey.
really hoping soon. I am taking notes. And so this registry is actually through North Star Registry. And I am making comments right now so I'm collaborating with all of our researchers. What do you want to know? What do you want to hear? And so I'm trying to really reflect that our surveys reflect what our researchers need when they're coming up with cures, treatments, and interventions.
Researchers like Dr. Barry, Dr. Judy, Dr. Lai.
Yes. So I've put out, and they all seem to say the same thing. And so that makes it easier for me.
Great.
What does the patient want? What are their specific highlights of what they would like fixed, that type of thing. So
we went down a little bit of a rabbit hole for the FDA, which I'm glad we did, but I also want to like pull back and going back to the seizures in Penelope and Govorestat trial in 2021, like where, over the past 4 years, is she still having seizures? Is this something that is, you mentioned it was well managed. Like, what does that look like?
Okay. So such a mess. So, we were on the drug trial, and I definitely feel like we kind of took on the placebo aspect, like, the placebo effect where you think you're on drug. We are so hopeful, thinking she's on drug. The very last year we're in this drug trial, Penelope starts to deteriorate and she starts to go downhill really quickly. And that's when I started realizing, I'm like, she's probably not on drug, but I didn't want it to be true. She's probably not on drug. The seizures started to becoming progressively worse, and they were advancing into a more significant seizure where she was gone like for a minute. And I'm like, this is bad. This is progressively getting worse. And it just takes so much time to fix that and to go to the hospital, to get the EEG for a week. Like for me to be in the hospital with Penelope to figure out where the seizures are coming from. And they have to capture that seizure in order to treat it. And it's really hard to capture a seizure sometimes because it's not necessarily what's going on at home. And, if she's tired, if she's sick, those are things that make seizures worse. So we get on more medication. So we're on more medication and it's not really helping, but her whole kindergarten year, like her tests progressively went down. So she had lower test scores at the end of the year than she did in the beginning of the year, just kind of trickled down. And then May of that year, I think it was like 2022, we found out we were on placebo. And I'm talking of like knife to the heart. I thought I was a horrible mom. I made the wrong choices. I was bad. How could I have put her through all this stuff? And I just like, it was just a horrible experience. And nobody prepares you for that when you're in a drug trial. Like you to find out that you're on placebo and all your hope is just like sucked away. And then you kind of recover and you're like, well, now we'll see what she's like on drug. A week before we were supposed to start the drug, Applied calls us and said, over the last year, we've seen her kidneys start to show signs of damage. And we knew that, like, because they would tell us there's proteins in her urine and come back. And, so we did a repeat and they checked it and they said, we were seeing some kidney problems. And so it was just like, we're about to go on drug and then she has kidney problems. And because she has kidney problems, we're probably not going to be able to get on drug. And so we have to go to an outside person to get evaluated for her like kidney issues. And it was interesting. And it was just like heartbreaking at the same time because we went to the kidney specialist. She saw all the labs. She saw all the specialty labs from Applied Therapeutics, very extensive. And she said, I was like, is this, and she also got an ultrasound. The ultrasound came back clear. So that was our clear. There wasn't like significant damage going on, but there was stress in the kidneys. And so talking to an outside person who's not in the drug trial was an interesting conversation because she had some great insights about the kidneys and that she's like, I don't know if it's damage or if it's the metabolites that the kidneys are getting rid of that are causing like a false elevation. And she said, I'd like for you to go on this medication. I want to see if this will help. And she thought, this could possibly help the kidneys. And so she said, and if it doesn't, to continue the drug, we're going to put you on lisinopril, which is a medication for the heart, but it coincidentally helps the kidneys perfuse. So we had a lot of options, but it was like so weighted, like God's so heavy. And why are you always the 1%er?
Yeah. You have to take this medicine in order to take this medicine, but this medicine has this effect. Yeah,
so, sure. So we got on drug and I am such a hopeful person. And I'm always like, am I right? Am I wrong? And I'm like, I really believe that this drug has been life-changing for Penelope. Penelope was about 6 years old. Of her birthday month before or after we started. She was still in diapers. She was still drinking bottles. She couldn't really talk. She had a lot of meltdowns. It was a lot. And she had this horrible constipation. And that's another thing. Like when I tell people, regular people, that my child has constipation, like, oh yeah, we have constipation. I'm like, this is not the same. This is not the same. Right. This is debilitating. This is life altering. This is like a quality of life thing where she's literally doubled over in pain, constipation. And most people with that kind of constipation in the community totally understand. They get it and they understand it. But we were doing everything to manage the constipation. Like that was something that was like around the clock. I had to make sure that she took, oh my God, she had to take Miralax twice a day. And even with the Miralax, we had to do suppositories once a week. And she's just in pain all the time. Like I would try and go to the park and the constipation would hit her and she have to go. And then we're stuck in the car for like an hour for her trying to go. And that was the first thing that went away. No more constipation. Yeah. A simple,
after drug.
Yeah.
After being
drug,
on AT-001.
Yeah. Within 3 months. We still take magnesium gummies, just to help. Cause I believe that she's just still not, she has some hypotonia, but nothing like it was. This is easy. This is so easy. And by that December, she was completely potty trained. And like that.
Oh, and I feel like that's like a very real, because one of the things I think about with Govorestat specifically is like, how can you, like what real tangible things are you seeing a difference in that are different than like just a kid's regular development, right? And Brittany talked a little bit last week about memory, but I think like constipation versus not being constipated is such a very black and white, real, tangible thing of like, no, for 6 years, she was constipated every day of her life. And now she's potty trained and not is such a like obvious black and white difference.
And like to go back to the PFDD meeting, that was brought up a lot. And I have a family member who actually, I'm not gonna say who they are, but they were like, I am so sorry. I thought it was just constipation. And she's like, I know you're doing everything that you possibly can. And she's like, I didn't think you were. But to know that this is a whole nother, like it needs a whole new name. Galactosemia constipation is not like regular constipation.
So you saw Penelope start to progress, and did the seizures also go away with
oh my God, yes.
Govorestat?
So by August, we were able to take back some of the medication. And seizures are complicated. So seizures, when you're taking away medication, you have to be very careful because the brain is super smart. And that's why it's very important that if you do have seizures, you get treated, because your brain is so smart and has so much plasticity, like learning behavior in the brain, that say you have a seizure on one side of the brain and it's not well controlled, the other side of the brain wants to mimic the same thing that's going on. And so that can cause progression of seizures. So my doctor has explained it to me that if we take the medication away too quickly and there's still some activity going on, it can come back worse. And so we actually have an EEG scheduled April 9th to be the last one to confirm. And we've had them throughout, but this will be the last one to give the confirmation that she's seizure free. She is on the very last little bit of medication. And so we're going to go into the hospital, take her off everything, get the EEG, and see if she's completely gone. Like they're completely in remission. And that is when we're off everything.
And then will you stay off of everything, including Govorestat?
No, we'll still continue taking Govorestat. And my neurologist and the nephrologist, they've all taken note of Govorestat. And I see them take notes. They're like, interesting. And who's the person? And they start asking questions, because to see someone, seizures are not easy to control. It's complicated. Right. So when you see success happening with a drug, doctors want to know, because like at a specialty hospital with Joe DiMaggio, they're seeing all the kids with galactosemia. You know what I mean? Right. Or they're seeing all the kids with kidney disorders and stuff. So they take note and want to know, like, what is going on here? How is this actually working? Right. So she is just like independent and she just went from being a baby to now she's like this tween. Like, I kind of had to mourn the loss of a baby because literally at the beginning of the trial, she needed to be rocked and she had sensory issues and she needed to be held a lot and she had a bottle and she's still changing diapers. Sorry.
It's okay.
And now she's picking out her clothes at H&M, giving me direct opinions about the stuff that's going on. And, you know, it's just, wow. And her teachers at school, oh my gosh, like they see stuff like, I didn't even know she could run. Have you ever seen the Galactosemia mouse model on the spinning wheel?
No.
Oh my God. It's our kids.
Okay.
I love it. It's the cutest little thing. You have two mice on the wheels, like trying to go on, and you have the one that is like awkward and falling off. And like that was Penelope. And now she's at ice skating camp all day. I have these videos before and after that I have sent to the FDA. And I'm like, how can you not see what I see? Because I have images of her running and it's like slow motion. And then now she's like, I can't catch up with her. She's outrunning me. She can, like, she goes to CrossFit with my husband. Like, she's coordinated. She is powerful. And, you know, it's hard. And that's when I go back to this regulatory stuff, the patient voice. There's this thing called p-value. Have you ever heard of it?
Sounds familiar.
Okay. It is so complicated. Nobody knows anything about it. I knew nothing about it until it was important. And so p-value is statistical significance. And in order to have statistical significance, you have to have a p-value less than 0.05. Okay. And when you have a small population of 42 patients, I think it's 42 that was in the drug trial, p-value doesn't work. It does not work with rare disease. So this statistic is 100 years old. The statistician Fisher actually gave 0.05 is just arbitrary. There's no like actual rhyme or reason why. It's just like a base off of whether this is going to be these results are going to be significant to the outcome that this drug works.
Right. Well, and what you see is like, I think that probably works for a population like diabetes, like we've talked about, where it's like millions of people have this. Your test trials and your like all of these trials that have all of this data are a large accumulation in a very well developed like data set. But when you go to an ultra rare disease where only 3,000 people in the US have it and only 50 of them are in this trial or 40 of them are in this trial or 30, your data set is not really large enough for the same laws to be applied for the thing that can work in a very, very large data set. Now to apply that to something that's 30 people, it might not be fair. It's probably not going to be fair.
Oh, no.
And so that's what we're up against.
That is what we're up against. And that's why I say, like, you might not want to take drug. You might not believe in the drug. You might want to believe what the FDA is saying. But if you understand p-value and understand that, like when I go to experts and tell our story and they say, you have 10 people in placebo, 10 people in placebo. And they're shocked, absolutely shocked that was even done, that you even did placebo. Like how much statistical significance are you going to get that's reliable from a placebo of 10 people? Versus 42. And there's a lot of different theories on the how many patients would be significant for p-value. Some say it's 100. Some say you need at least 35% of the total population of galactosemia participating in a drug trial. People don't want to participate in a drug trial.
That's too many.
And that's a lot. It's just not realistic. And so when you're dealing with the realities that we are ultra rare and we have a small population, I actually helping experts accelerate rare treatments bill. And in that bill was to ask for small patient statisticians, to ask for them to use statistics, because there are statistical models that you can use that are much more updated. There's one that is called totality of evidence that gives like a more like whole look at the
view.
patient and their experience, and can put it into like a quantitative, realistic, like scientific proof that this drug works. And why aren't we using that? Because we don't want to take a drug that doesn't work.
Right.
So even in the future, if a treatment goes through there and they have statistical significance and they've met it, but it actually doesn't work. So helping experts, that the HARD Act, we as a community help get that passed. And they're still trying to implement it. I believe it passed in December of 2023, and the rollout is very slow.
Yeah.
So I watch a lot of hearings. Peter Marks and Patricia Calvazzoni has been saying the same thing for the 5 years that I've been watching them, that until we find a quantitative way to add the patient voice, there's really nothing we can do. And I've heard that so many times, and I'm like, we have new statistics. We have other options. And there are policies and procedures, back to why like I love policies and procedures. All the policies and procedures at the FDA have flexibility, and that like we could succeed, or we could have options where we can have a conditional approval where we do further studies, but at least it'll give access to the people who want this treatment. Because there are people now who can't get the treatment, who want to try it to see like, okay, will this benefit me? And that's what I do. I advocate for a lot of FDA flexible regulatory policies. I know for accelerated approval, there was a PDUFA package that actually Senator Biden signed, and I think that was like 2023 too. And it was like, I was able to change one tiny little sentence about accelerated approval in a 500-page document that kind of, gets us going. It's so hard. It's a lot of work. That's why I need lots of participation. Like I need other people helping me.
Well, and I want to, so we've been going for an hour and a half.
Oh my God, I know. And I don't, I just, so much.
I know there is so much. And that's why what I want to do, so I want to end the episode here so that people, because if you've been listening to this episode for this long and you've gotten to this point,
oh my God,
then thank you. And no, it's great. I'm sure people, like I have loved hearing just the story of your journey so far. And what I want to get to, and what I'm going to do is a part 2 of this episode. You and I will sit down again and do a second episode, that now that we are familiar with all of the things that led you to this point, I want to get into helping people in the community, which you do a ton through advocacy, and like just even replying to people, your large to-do list, which you talked me through the other day, getting a $2 million grant to fund studies for newborn screenings, all the work you're doing there, how you work with the FDA and fight for us in the community, and just how people can get involved. All of this stuff is going to take another hour and a half next time we sit down. So I want to wrap it up here and get to all that other stuff on the second episode that you and I sit down and do. But first, I don't want to miss just saying thank you for sharing your story and for being so vulnerable and so open. And it has a huge impact on our community, and it has a huge impact on the people that listen to this podcast and go through similar things. And so, just thank you for actually taking the time to dive into all of that stuff.
Well, I appreciate it. Thank you so much, because I definitely need help communicating, because I kind of just...
You do a great job.
I do talk a lot.
That's why you're so good at what you do. And this is a reason for people to watch the YouTube videos. You've got your puppy. What's her name?
Oh my gosh, this is Juno.
Juno. Hi, Juno. You're so pretty. So pretty.
She started whining. I was like, oh God, I got to pick her up. Otherwise she's...
You gotta check out the YouTube version so that you can see Juno. Gillian, thank you so much for joining us. You and I are going to sit down again and talk about all the advocacy stuff in another episode soon. But I really, really appreciate you taking the time today.
No, awesome. Thank you so much. I appreciate it. Everything.
Yeah, of course. All right. We'll talk to you soon.
Take care.